Hello and greetings from RFA Tutors this side. Thank you for joining us today. Hello, friends. Is my voice audible and is it clear to all of you out there? Hi, can you all hear me? Hello, Salma. Hi, Sana Said. Thank you very much for joining in, everyone. Hello, September group. Hi, Amrita. Hi, Darshana. Hello, Preeti. Hi, Shamaila. Hi, Padma. Thank you very much for joining, my dear. Hi, Kazi. Lovely seeing your name here. Hello, my sweetheart, Kia. Hi, Minahil. Hello, Mufida. Thank you very much for joining in. I feel nostalgic seeing your names here. Hello, Rizwana, Sabah. I hope you all are fine. Long list. Thank you very much for joining in. I'm really grateful for all of you to join us today for the first session for MRCPI September 2022. So I welcome all of you on behalf of entire RFA team here today. It gives us an immense pleasure to commence a new MRCPI batch today for September year 2022 MRCPI written exam. We are going to have an introduction and we are going to talk about MRCPI essentials today. We believe in ourselves and we can achieve whatever we are believing in and whatever we are working hard for. So we have to basically make an aim today. We have to take an oath today that we would work hard keeping this September exam in mind and make it a success together. We are going to see that why MRCPI, that's an important exam, and why shall we take this decision to attempt an MRCPI at the very first place? How do we prepare for this MRCPI written exam? How does it differ from the European board? How does it differ from the MRCOG Part 2? Why at all the students tend to fail in this exam? How to make it in one go? And what is going to be the outline in the course, and a very important update we are going to talk about today, that is your 2022 update on a molar pregnancy. I will tell you how we have to study the Irish recommendations. We, as a team, I will ask all students sampling performances. Thank you. I was saying that we as a team would like to thank wholeheartedly to all those students who had exemplary performances and spectacular results, reaching to heights. Now they've made it possible in the March attempt through the hard work, through the persistence, and of course, determination. Now, students from all parts of the world had been working hard, hands in hands, working as a family. It is indeed a target-oriented approach we all require in this journey. Now, the very first question which comes to me when we are starting up this course is that, ma'am, we are in MRCOG. Why should we take a decision of having MRCPI? Ma'am, we have our EPCOG degree. So what is the additional benefit of MRCPI? Here, I would like to guide all of you out there that I've brought in from various parts of the world, the students who have cleared MRCPI, and they're going to tell you that what benefit does it give to you guys. I would like to invite here, being online, a very, very prominent name of MRCPI, running so many groups, a very dear friend and colleague and part of a RFA as well, Tehmina, who is living in Brunei but is from Bangladesh. She would tell you, and I know many Bangladesh students are there, she would tell you that what benefit does it give? I mean, working there, and also I would like her to tell you that what advantage a person can have. Now, working in different parts of the world, having this degree would give you the exact clue and make your job easy to take this decision for yourself. Hello, Tehmina, how are you doing, my dear? Hello. Hello, good day, Tahmina. How are you? Okay, I'll give you the permission. Yes, just a second, my dear. All right, Tahmina, please unmute yourself.
Hello. Yeah, now
Hi,
I
how are you
can.
doing?
I'm fine. How are you?
I'm very well. Thank you very much. So all my Bangladesh students must be knowing Tahmina Apu, right? Yeah. All right, Tahmina. Tahmina, people would be actually glad to know that what exactly the benefit MRCPI gives and what advantages does it make to you? Yes, please.
Yeah. And nowadays it is now same quality of MRCOG, and also in Bangladesh this is also recognized, I think so. And anywhere in Bangladesh, if you want to do any job, this is also one good quality. You have one degree that is they accepted there. So it is very good thing. And also if you want to move from Bangladesh to any your country like Ireland or England, both of the places you can move with this degree. So it is very good things. I think MRCPI, third part is more easier than the MRCUG part 3. So
Yeah.
I think it is very good in anywhere. In Brunei also they are accepted this degree.
Wonderful. Thank you very much, Tahmina. It really improves into knowledge as well. And of course, your
Yeah.
pay package financially and the work environment, everything is improved by that. Thank you very much. All the Bangladesh students are so happy to listen to you, my dear. Hats off. Arif is proud of you to have in the team. Thank you very much, my dear. Thank you. All right. So this was Tahmina, friends. I'm here with Fadwa. Fadwa works in Oman. Hi, Fadwa. How are you doing?
Hello, how are you?
Hi, good to see you, my dear. Thank you very much being here. So Fadwa is going to give you an information. She just passed the last MRCPI. What effect does it make in Oman, countries like that of Kingdom of Saudi Arabia? Yes, Fadwa, what would you like to say to friends? Why do they take this initiative to take this MRCPI?
Yeah, actually MRCPI, I got this MRCPI because my friends advised me to do. Already I was studying for MRCOG.
Yeah.
Then it is here in Oman, in Saudi, they are dealing with it. Same for RCOG.
Yeah.
So you will be promoted same the degree of RCOG. So you will be promoted to be specialist. This is here in Oman and Saudi. Many of my friends.
Perfect. Yes. Yes.
And
Okay.
it's a good, it's a nice achievement, and it is compared to RCOG. I think it's an easier, but still you have to work hardly.
Definitely, yes. This is what I'm going to focus today on. Thank you very much. Thank you, Fadwa. Take care of baby, my dear. Thank you for spending your precious time.
Yeah,
All right.
thank you very much.
Thank
Okay,
you,
bye.
Fadwa.
All the
Lovely
best
having you
for
here.
all.
Thank you so much.
Okay,
Thank you.
bye.
Do remember
Bye.
in prayers. Thank you.
Bye.
All right, friends. I've got
Bye.
one of my pioneer student here today, and Mavra from United Arab Emirates. And I would like you all to know that Gulf countries, they really go for this. I know that my Irish students, definitely they have this compulsion to take this exam, right? But other than that, it's really popular to do MRCPI in Ireland. Mavra is going to give the input. Hello, Mavra. How are you doing?
Hello, Dr. Sidra.
Thank you so much. Walaikum assalam, my dear. Happy to have you here, friends. Mavra was one of my pioneer students when we started and can never forget because these are some senior students which I had. And Mavra, people would like to know from your side, what difference does it make working with MRCPI, my dear?
Yeah, actually, I'm working right now in Dubai. So in Dubai, like whole UAE, MRCPI is recognized as a specialist degree, and it is considered equivalent to MRCOG. And of course, like it will, when you study for these exams, it aids into your knowledge, and it's a post-graduation, and it will improve your weightage of your CV and will help you to get if you are moving to UAE or Dubai, so it helps to grab the job. And secondly, after if we pass this exam MRCPI, after 3 years we can be promoted as specialist in UAE. And the other thing that now with MRCPI, we can get GMC registration and we can work in UK as well. And I have already got GMC registration and now I'm hunting job in the UK. So most probably I would like to relocate to UK with this.
Perfect. Thank you very much. This is what is a change from last year onwards, Mavra, that we got another route for the GMC registration because people are struggling with MRCOG3 and they find it difficult, of course, because certain paths, because of the COVID situation, seats getting scanty, not being able to appear, then definitely in comparison, the MRCOG is definitely a little more saturated and difficult in passing as compared to MRCPI. So I quote, and they say that MRCPI in obstetrics and gynecology that's recognized by General Medical Council in UK. This means that international medical graduates can apply for full registration with a license to practice in United Kingdom if they hold MRCPI in obstetrics and gynecology. So as per experience, this route is an easier route, as Mavra is saying. So that definitely gives an additional advantage. Thank you very much, Mavra, for taking out precious time. I just wanted students to know that this is something which is of the equal benefit and we can work hard to get an additional degree. Thank you very much, my dear. Thank you for being present here today. Thank you.
Thank you.
All right. Thank you, my dear. Thank you. All right, friends. So this was a little introduction to tell you guys that with the same preparation, 30% of more effort, we can add on with MRCOG, MRCPI to our name. And that is just 30% of more effort, I would say. I would quote that welcoming this decision from RCPI President Professor Mary Hogan, and he said that this is a significant development that widens the training and employment opportunities for doctors who have achieved our postgraduate qualification. Our college has always had strong links and excellent collaborative relationships with our colleagues in United Kingdom. This is further recognition of the high esteem that our membership exams are held in as a mark of attaining high quality medical training. I unquote Professor Horgan, he said. So with this introduction, we should know that what is the curriculum and what is the exam pattern. Now, as compared to MRCOG, why we say it's easier? Because students are so scared of the extended match questions. I'm sure you all would agree with the same. Exam paper is just one. The duration is 3 hours. The question types are the single best answers only, and 100 single best answers to be done in 3 hours. And they've got 5 possible answers, A, B, C, D, and E. And we don't have any negative marking. So as compared to MRCOG, where we are so scared of the extended match question, we've got 2 papers and with 50 SPAs and 50 EMQs, as compared to MRCPI, where we've got 100 single best answers and a single paper only. Now, so far, it is still in the test reach from home. There had been no announcement to be in the center. And in addition to MRCOG curriculum, you people would do Irish guidelines. All right. So I would like all of you to know that how we are going to make it easy. What is going to be that pattern which would help us to learn that in a better way so that the input is less, but definitely the output is more. Now, the open students of the Telegram and the Facebook who had been contacting that I've got my fellowship of College of Physicians and Surgeons, Pakistan. Can I take this exam direct? Yes, the MRCPI 1, that is exempted for you. Then all my MRCOG students all over the world, they message that, ma'am, I've got my MRCOG part 1. Can I take MRCPI 2 written direct? The answer is yes. You are exempted from MRCPI 1 if you have the following degrees that are basically visible on the screen at the moment. Okay, so with all these, you can directly take your MRCPI Part 2 written till date. It holds true, and you can utilize your your degrees for directly appearing in MRCPI Part 2 written. And we had a lovely day of the registration and booking with so much of activity in the Telegram group. All the team, all the moderators, including me, we all were together and we had been able to submit all the applications. For the newcomers, please, it's 18 months of post-registration training in the obstetrics and gynecology. It can be 9 plus 9 months or a complete 18 months. This is what you require. If you have any query, drop in a message in the open Telegram, and the team 24/7 RFA is there to guide you guys. All right. Okay. Now, what are we aiming for, friends? When is the exam, by the way? Thank you so much, Mavra. Thank you very much for being here, sweetheart. Thank you. When is the exam, by the way? What are we aiming for? We are aiming for, Talha, when is exam? 8th of September, right? Yes, 8th of September, Muna, lovely. 2022, that's going to be your exam. We have had the opening date of applications, which we have successfully done on 7th of June, 2022. They're still open, but the earlier you do, the better it is. And I'm proud of all the students in the study group who have done it. That's wonderful. That's great. Now, during this preparation, what are the problems which we face? Whenever there's some exam ahead, I always say that the very first day, we should be target oriented. I would like to emphasize, and is the first day of start to a new journey. Therefore, being on the right path is super important. I mean, it's so essential to be on the right track. We all say, and you would find it everywhere, that MRCPI is comparatively easier exam. I stand by these words and I agree. But does that mean that college gives 100% result? Does that mean that no one fails in the exam? The answer is unfortunately no. Now, none of the exam is easier if we don't prepare it as per requirement. Would you all agree with this? Yeah? If we say that MRCPI is an easier exam, okay, we'll just read in the last 10 days, we are putting ourselves into a false paradise and we are putting ourselves into a difficult situation. Do you all agree with me? Is it? So the problems are having a non-focused preparation. The problem is having a wrong examination strategy. The problem is having an examination stress in the last 10 days because we didn't open up the study schedule earlier. And the problem is with the mindset issues that, oh my God, it's so easy. I'll just do it in the last 10, 15 days. So Rihanna, Kia, Muna, Talha, everyone out there, all the people in the study group who have not yet joined, who would be listening to the recordings, from day one, I want solutions to these problems. And that is, from day one, we would know that what do we have to do, how we have to cover these days with a targeted approach, with a super time management, with our perfect willpower, and resolving these with a focused study. Salman is absolutely right. None of the exam is easier if we don't have a good preparation. And if at all the preparation is good, I would definitely say that last students, which you just cherished their memories in the beginning of the session today, they scored 78, 79, 81. You can see on the scoreboard in the open group and in the Facebook, they were just like you. But what was the difference? The difference was that they made a perfect 90-day schedule. If you follow that and you exactly know which I'm going to teach you today, that was the way of studying. How do we study basically? And we understand today, when I'll give a smaller glimpse of the new update, May 2022 to you guys, you people would understand perfectly that what is the best way to retain. And you people would love it the way you'll study, if at all, just once in comparison this guideline. So we have got Irish guidelines. All the summaries are available for you guys. The green top guidelines, I will tell you exactly what you have to learn. The NICE and the talk articles, the Faculty of Sexual and Reproductive Health as well. The single best answers books are very, very important. We are going to make the changes as per the RCPI curriculum as well. These single best answer books are same as you did for MRCOG, but 6 to 7 guidelines are different. Therefore, we would update as small for gestational age, as NTD, as venous thromboembolism, these have difference in their recommendations, and we would update in the study group that what are those questions where we need to change the answers. Moreover, we have got a perfect book for this MRCPI question pool together. Students, they love it because they see that so many questions are out of this. In the study group, you're going to have a discussion upon this, and just 30 days before exam, you people would cram it up the MRCPI question pools separately, right? For all those who are messaging for joining in, my MRCT Part 3 students, the Open Telegram and the Facebook students, I'm sure now you are clear in different parts of the world, why shall we take MRCPI? And I know after July exam, many of you are intending to take this. So the live sessions are going to be me only. And we are going to have the record until the exam date. The written summaries of the GTG, the NICE, the talks are with you within Irish guidelines, updated till date. I mean, the guideline, which is published like 2 days back, we have its recommendations updated on the website as well. I am strict with team on this, like 2 to 3 days is the maximum time. Whenever some update is there, that has to be on the website, because I know that how important it is to stay updated, because the older recommendations, they go obsolete. And if the students, they talk about, you know, the older things, I always tell them that stay till date. I mean, the recommendation of the day is the most important. Why? Because that creates a difference between the updated student and the student who is doing the older recommendation. So even if you talk about me, all my sessions in every course, they get like updated, they get changed. That's the only way of survival. You need to be updated. You need to study the newer things, right? So all the Irish guideline flashcards and summaries we are going to discuss, I will do that all the module wise in the live sessions, and we'll have self-assessment discussion as per the mock. So let's get started with this discussion of introduction. Every 1 week, we are going to meet with module-wise Green Top Guideline, NICE Guideline, and the Irish Guidelines. And we are going to discuss the differences. You are going to keep your notes of your previous degree, like MRCOG, like European Board, and we would make it sure that we understand what are the differences which we have to learn. Hi, Peter, how are you doing? Tala will discuss about that. Yes, my dear. Rania will tell you about in the study group, my dear. Okay, all right. So the students which have not booked and they're asking me the details before I go to the topic of the day. When we started up the registrations, it was $449, and I promised that only for 24 hours, it's going to reduce as a booking gift to $149. Just now, for another 48 hours, it would stay $149 USD. I repeat, it's USD, please. It's not pounds, because that's going to be higher. So it's $149 USD. What you have to do is that you just have to sign up on the link, and you put your details of the card and go to Got a Coupon. If you go to Got a Coupon, you put the RFA BOOKING GIFT, the RFA booking gift, and validate. It's going to reduce $300 immediately. Then you can, after validate, you can do a checkout. All right. But it is going to be for 48 hours. I'm afraid would not be extended further, because many of the students just in this time period, they've booked for full. So that puts my position into a difficult one. I hope you all understand, right? This is going to be from 48 hours from this point onwards, because many people wanted to know the information regarding why to take MRCPI, and that's what we wanted to share today. All right. Thank you very much, Rania. Thank you. Okay. Now, you know, 3 days back, there was a publication. How many of you know that there was a publication 3 days back, by the way? How many of you know that 3 days back, we had a recent Irish publication? Mufida, student like you should take both of them, my dear, both of them, Mufida. Reason is that I know you're tired. If you want me to ask the first one, take MRCPI September, Mufida, right? And the November MRCPI OSCE. So in just 3 months, you can take over, because now there's no backlog in the OSCE. The ones who passed the March MRCPI, Mufida, they got the seat in the OSCE for May. So if you'll pass September, God's willing, you can get the November seat. So in just one go, you can have your MRCPI done till November. Got it, my dear? Yeah, Rubama, now it's easier because the backlog is over. For written, again, it's little tricky, but OSCE backlog is absolutely over. So Rubama, my suggestion would be take the MRCPI September And as I'm saying that the March students, they got the May acceptance. All my new students who passed in March, they got acceptance, but few of them could not reach out because of the visa problems to Ireland. But the November one is in United Arab Emirates as well. So the traveling is not going to be a trouble more. Okay, so take the exam in September and the November OSCE. This is going to be the best way for all of you. Okay, thank you very much. Yes, Javeria, now almost the backlog is over, so they're going to be faster. For part 2 written, it's still a little tricky, but for the OSCE, no backlog is there once you pass, right? They're giving the acceptance so quickly, and repeated reminders were given just even 1 week before exam. They were giving the reminders to the recent passing students. All right, Rubaba? Okay, Mufida. So see you guys in the study group, Mufida. All right, thank you, Rubaba. All right, okay, so how many of you know that we had a recent publication? How many of you honestly tell me that we got a new guideline? Did somebody know about this? My MRCPI OSCE students know, November OSCE students. Why? Because I think Tehmina shared a few days back in the study group, right? If Tehmina is here, yeah? All right, okay. So we had a lovely update of the diagnosis, staging, and treatment of patients with gestational trophoblastic disease. Yeah, Shazia, it is just published 4 days back, right? And this is a new Irish update of May 2022 on the molar pregnancy. Now, when a new update comes, I want to teach you today, not only the topic, but the way we have to learn. Because I know that the students who are coming to MRCPI, hardly 10% are raw, or 10% are the ones who are taking the exam for the first time, like the professional exam. Either these students are from MRCOG, or these students are from EPCOG, the European board, or these students are, these students are from the local exams, like the fellowships of their own countries. So hardly I get the students which are very raw and they're taking for the first time. So definitely they've got some basal level. Thank you very much, Tehmina, my dear. Thank you. So hardly the students are who don't have the basal level. Now, if you have a basal level, what do I expect from all of you? My expectation is that you open up your MRCOG notebook. For example, Javeria, you, Talha, Kazi, my dear, yeah, all my European board students, you open up your previous notes and you add on the differences. For example, you take your red pen and you write in front of that, okay, this is the difference, and highlight that. I don't want you guys to make a new memory. Why? Because you've already made an effort on your past degrees. This is what I did for myself. I made my MRCOG notes perfectly, right? And then I made the changes for MRCPI upon it. So isn't it a better way rather than starting from like A, B, C and making absolutely a different notes and putting like 100% effort from zero again? Do you people understand my point of view? I will tell you exactly today when I'm doing this guideline, you people would understand. What do I mean to tell you in this molar pregnancy? And I promise that you do it for once only, you would never forget the GTG and the Irish. When I'm taking MRCPI part 2 session, I tell them, okay, the GTG says this, the RCPI says this, or the European board says this. Why? Because I've got comparisons in front of me in my notes, right? I want to teach you exactly what's the right way. Today, the topic is not a bigger one. It's hardly 10, 15 slides, but I want your approach to be perfect from day one. I want that we be very smart students from day one. It's not about like spending 2-3 hours in a guideline and then forgetting it. Whatever we are doing, we need to retain it, right? That's a perfect student. Now, what are we going to do? The first recommendation of this guideline says that ultrasound examination can be helpful in the pre-evacuation suspicion of complete molar pregnancy, but the definitive diagnosis is made by histological examination on the products of conception. Now, you tell me that this is 2022 May update. Is that different from the Green Top guideline? Javeria? It's absolutely the same as per the Green Top guideline. So we don't have any trouble. We learned this point. Okay, GTG says that ultrasound examination is the pre-evacuation way of diagnosis and the histological examination is the post-evacuation, and the word definitive diagnosis come in the single best answer, Shazia. Yes, Kia, the definitive diagnosis if they're asking for in the single best answer, that's the histological examination. So it's absolutely same as RCOG. No need to burden your neurons for this. Okay, Laboratories examining the products of conception should have an access to P57KIP2 immunohistochemistry to aid the differential diagnosis of complete, partial, or the non-molar pregnancies. The Green Top Guideline also tells us, and this is your famous Sir Andrew Sizer's single best answer as well, that says that P57 immunohistochemistry, that does a differentiating point. However, they say that as a recommendation, they do say in GTG that it should be done. However, RCPI makes a very strong grade of recommendation for this, that all laboratories should have an access. So the recommendation is an Irish guideline. The point is mentioned in the Green Top Guideline as well. Do you people understand the difference? Here, it's recommended that when you are sending a product of conception, it should be to the laboratory who has the access of this immunohistochemistry. Do you people understand the point? It's a recommendation that that laboratory should have an access to P57. Am I clear? Did you people understand that how we have to pick up the differences from here? So P57 is basically the immunostaining, friends, and that classifies the lesions and immunostaining that's absent in the complete high-identity-form mole, and it is going to be present in the partial high-identity-form mole. All right, so this is how you have to make a comparison, and never in life I would be ringing in your ears and you people would not forget that. The guideline update May 2022, as per the Irish recommendation, says that the histological assessment of material obtained from the surgical management of all failed pregnancies is recommended to exclude trophoblastic disease. And it's a strong grade of recommendation. Now, they add on to this by saying that all women undergoing medical management of miscarriage or medical termination of pregnancy should be advised to perform a follow-up urine pregnancy test 2 to 4 weeks after miscarriage and termination. Now, where is the difference? I have given you the permission to be unmute. Can somebody tell me that is it absolutely the same, or do we? Thank you, Rania. That's my girl. Love you for very keen knowledge. Thank you, Muna. The Green Top Guideline says 3 weeks. Very well done, Talha. Very, very well done. What about the first recommendation 2.2.1.1? What about the first recommendation? Is it the same? What do you guys say? What about the histological assessment in the Green Top Guideline? This is specifically both of them in RCPI. Why? Now, how we have to train ourselves. Today, I'm telling you that I'm not only covering the topic, I'm telling you the way to study MRCPI, right? Now, if you go to the Green Top Guideline, it says, and I quote from the Green Top Guideline, that the histological assessment of material obtained from the medical or surgical management is recommended only if no fetal parts are identified. So what is the buzzword? Do people understand? The GTG says if no fetal parts are there, then only we are going to send. And the Green Top Guideline says that urine pregnancy test following a miscarriage would be 3 weeks after the miscarriage. Now let's go back to the Irish recommendation, friends. What does the Irish recommendation say? The Irish recommendation say in this situation that we are going to have the recommendation in terms of the histological assessment, and this histological assessment is material obtained from the surgical management of all failed pregnancies. It is going to be sending there. All right, okay. Now it's also 2 to 4 weeks given. 2 to 4 weeks given, and in the RCOG they say 3 weeks. Okay. So please remember this for exam. This is how we are going to understand that this is the important part, and this is how we create the difference. Okay. All right. Now you people understand that it is a situation where we need to make a comparison. All right. In this, we have to make a comparison of the Green Top Guideline, the recommendation, and we have to make a difference that what the Irish guideline says. In cases of suspected molar pregnancy, a pathology report should be available to the clinician within 14 calendar days. Okay. Now you tell me that where in the Green Top Guidelines something like this is written. All right. Where is it written that it should be 2 weeks? It is given in the strategy, but we don't have this at all in the Green Top guideline, right? In case of suspected molar pregnancy, a pathology report should be available within 14 calendar days. So this is something which is recommended by our CPI. They say if the molar pregnancy is suspected, the requesting clinician should indicate their clinical suspicion on the pathology request form, and they should inform the pathologist as well. Thank you, Muna. These are additional recommendations as per our CPI. If molar pregnancy is suspected, the requesting clinician should indicate their clinical suspicion on the pathology request form. So please keep a note of that in exam. The guideline development group recommends that all women with suspected gestational trophoblastic disease should be registered and with the National Gestational Trophoblastic Disease, that's registry. Now, this is also given in the Green Top guideline. Very good, Rania. Very well done. Now we understand that in this situation, same recommendation. So you don't need to burden yourself. It's not going to be a burden because you people understand that this is the same as that of RCOG. Okay, perfect. Now the human chorionic gonadotrophin, that should be measured using an assay that is CE marked for oncology. Don't worry about this because it is something which is a standard, which is done for any sort of a treatment that's being done as per the onco, right? For patients with complete hydatidiform mole, the serum HCG is monitored weekly until the normalization is achieved for 3 weeks. Here, I would like to have, thank you, Talha, perfect, London, Sheffield, and Dundee. Here, I would like to take your attention, please. If you people remember, and if you remember my molar pregnancy session of MRCG part 2, I tell you guys that this is the gray zone in RCOG. They don't tell us that how frequently we need to do human chorionic gonadotrophin. Do you people remember? This part is short of information in RCOG. Yes, we do take it from the strategy, but we don't have it in the Green Top guideline that how frequently we need to measure HCG. However, they do say that if it within 8 weeks, it becomes normal, then yes, the follow-up is going to be the 6 months time, right? Post-surgical evacuation. The recommendation 2.2.6.1 that says that HCG is monitored weekly until the normalization is achieved for 3 weeks. What does it mean? In single best answer, if they say that today the evacuation has been done, so for the next 3 weeks, how frequently you're going to do the serum beta HCG? And this is a very common question of our CPI, where they want you to know the follow-up of the hydatidiform mole. So how frequent you people are going to select in the single best answer? Very well done. Javeria, weekly for how many weeks? Salma Osman, weekly for how many weeks? 3 weeks. Very well done. Now, if within 8 weeks post-evacuation, then it becomes normal, then monthly for the 6 months. That means 4 weekly. And if it becomes normal after 8 weeks, then monitoring is 6 months post-normalization. Now, the 6 months thing is absolutely same as that of the Green Top guideline. Do people remember the Green Top guideline recommendation that within 8 weeks, if it's normal, it would be 6 months from the time of evacuation? And if its normalization occurs after 8 weeks, then it's 6 months from the day of the normalization. Do people remember this? Thank you, Rania. 56 days or 8 weeks as per the Green Top guideline. However, this weekly recommendation is different. Now, there's a few new terms. Students, they tend to get confused on this. CE marking is simply, it appears on many products, friends. And that basically says that it's an extended single market in the European Economic Area. And they signify that products are sold in having a standard. Okay, so that's an environmental protection requirement. Whenever they use this word, don't get confused with this. This is a standard word for keeping up a good standard for this protocol. Okay. The next recommendation says that for patients with partial hydatidiform mole, the serum human chorionic gonadotrophin should be monitored weekly. Now, this again is different because this weekly thing is not given in the Green Top guideline. The Green Top guideline does not tell us that it's going to be something weekly for us to be checked in exam. However, until normalization, it's weekly. So what is the rule of thumb? For this, we need to remember for exam that whenever they say weekly, that is until the HCG gets back to normal. So until and unless it gets back to normal, it would be weekly beta HCG until normalization. And the day it gets back to normal, after that, it's going to be 4 weeks, another confirmatory test. So this 4-week things, if somebody has done the updated Green Top guideline, you all know that this 4-week is the recent recommendation in the new molar pregnancy. Have you people read that, please? Have you people read that, please? Yes, Preeti, very well done, my dear. Thank you, Shazia. Thank you, Muna, perfect. So I repeat that once again, that it's going to be weekly, 8cg, the day it gets normal, then after 4 weeks, a second 8cg and the partial follow-up is complete. Amber, is it clear? Yes? Rayana, is it clear? Exactly, Javeria, very well done. Why? Because we didn't have this part in the Green Top guideline. Perfect, okay. The 8cg testing should be centralized in women with a confirmed gestational trophoblastic disease registered with the National Gestational Trophoblastic Disease Registry. So please keep a note, the ones which are same recommendations, just keep on being there in your notes, and the different ones you're going to highlight. Now, the FIGO registration in terms of the scoring and doing the chemotherapy regimens, that is the same. The gestational trophoblastic neoplasia, the same FIGO score we are going to take from the Green Top guideline, that is the same. And the indications are given in the strategy. They're not given in the Green Top guideline. If it's a plateau or rising human chorionic gonadotrophin, if it's a heavy vaginal bleeding, if it's a histological evidence of choriocarcinoma, the evidence of metastasis in brain, liver or gastrointestinal tract, or the radiological opacities like more than 2 centimeters in the chest X-ray, these all would be given, and in the single best answer, we would select the chemotherapy. Now, I would like to ask a question here. How many of you remember there was the cutoff of FIGO for a single agent or a multiple agent chemotherapy, please? Muna, Rania, Amber, Preeti? Thank you, Shahina, my girl. Very well done. Very well done. So it is very clear that it should be less than 6 or Talha 7 or more. Talha, please message Sumaya to join in. She asked me to remind her, my dear. She might have forgotten. Please message Sumaya. Huh? Thank you. Okay, women who have raised HCG 6 months after evacuation with a falling HCG should have treatment plan discussed with the National Gestational Trophoblastic Disease. Now, it's a different recommendation here, that if HCG is raised 6 months after evacuation with a falling HCG, this is a very, very important point. Why? Because in Green Top guideline, this point is not touched. A patient is there and she is having a follow-up. You all have to understand this point, please. She is having a follow-up and HCG is falling. So we are happy that the HCG is falling, right? But she still have raised. I mean, not coming back to normal till 6 months after evacuation. So that is an indication that we have a chemotherapy discussion with the National Gestational Trophoblastic Disease Registry. Okay. At the same time, if 4 weeks have passed in the follow-up, friends, 4 weeks have passed in the follow-up, and the beta HCG in the exam question of your single best answer, that stays 20,000 and more after evacuation, right? Again, that needs to be discussed in the National Gestational Trophoblastic Disease Registry. So I repeat this recommendation again, please. I hope you all understand. This is if it's persistently being raised, no matter it's a falling pattern, but if it's raised in 6 months, not coming back to normal, or in 4 weeks, it's equal or more than 20,000. That is going to be discussed in the National Gestational Trophoblastic Disease Registry. What do we need to do for this patient? Because it's a high-risk patient. You all are absolutely right that FIGO score of 0 to 6 can be a single agent methotrexate with or without folinic acid or actinomycin D. Now, taking into account the treatment cycles, we are going to check as per the agreed protocol. In MRCPI, they don't want you to test for the very typical or the basic or the very strong questions of the chemotherapy. They don't want you to know the regimens, but yes, you should be knowing that when to give what, like in terms of scoring, right? So 0 to 6 would be single agent. And they say that chemotherapy for low-risk disease should be like continued for 3 cycles of consolidation treatment at a standard of 2 weekly cycle after HCG normalization. So a continuation of 3 cycles that should be done. Consolidation treatment is the basic what we start with, the intensification when we start, not the maintenance, right? If at all the FIGO at the beginning is 7 or more, then the single agent would not be selected. Then it would be a multi-agent chemotherapy. And you all know the EMACO, the famous regimen for the FIGO 7 or more score, same as that of RCOG. In this condition, there are 2 additional recommendations which you all have to remember. When we were studying the Green Top guideline, do you people remember that we did only 6 and less and 7 and more, right? Have you people heard about 12 score cutoff or something like that? Does somebody know if the FIGO is like so high? If the FIGO is like more than 12, what's the difference? Do we have any difference, please? More than 12. Yes? Rania is reading. Yes, Rania? No? All right, I will tell you. They say that we have got an ultra high risk gestational trophoblastic neoplasia. And in that situation, they say that additional chemotherapy, it is there, and the deaths can be reduced by induction therapy with etoposide addition or cisplatin. Why? Because they say when the FIGO score is 7 or more, these are high-risk patients, so we require multi-agent. But if it's more than 12, these patients are ultra high-risk patients with early deaths potential, right? In that situation, the chemo start, that is the induction therapy, that would be with etoposide and cisplatin as well. Do people understand? They have made another category of ultra high risk of gestational trophoblastic neoplasia, which is specifically in RCPI. Are you all with me on this? Did you people understand that what difference does it make? If they tell us an additional high category where we need to add additional chemotherapy, etoposide and cisplatin, right? And they say that even if it's a low-risk gestational trophoblastic neoplasia and you have started off with the first-line chemotherapy, the first and the second course of the chemotherapy, that has to be inpatient. I repeat that once again, Preeti. Preeti, for example, Rania, for example, you get a single best answer in exam that a patient has got a 6 or 5 FIGO score, right? So what is going to be the chemotherapy of choice in exam, please? What are you guys? Thank you, Rania. Perfect, my dear. For FIGO more than 12, etoposide and cisplatin, right? Okay. So my question was to all of you out there that if it's going to be less than 6, what is going to be the answer for the chemotherapy selection? Talha, Rania, Preeti, Rubaba, Muna? Less than 6. Yes. Tell me the name. Methotrexate. Perfect. Now, if they give you methotrexate outpatient, methotrexate inpatient, and there are 2 options, Talha, what would you guys select? Now you understand that have the single best answer, they're going to play around with the words only. Outpatient or inpatient? See the recommendation 2.4.4.1. See the recommendation 2.4.4.1. Now everybody would start changing the answer. I knew it. Did you people see? They recommend now that at least first 2 courses, they should be inpatient. No matter their low risk. Very well done, Shaista. Very well done, Javeria. These are the updates. Now, you people will put a stick on your molar pregnancy and just write these one-liners. Right, Shazia? Do people understand why am I telling you like it's not different? The first time it's going to take you 30 minutes, but you will never forget in future. All right. And the monitoring with the chemotherapy as per the Irish recommendation is basically by the HCG. And when the HCG gets back to normal, so 3 further consolidation cycles, the intensification cycles are being done further after getting normal, please. So any patient who has the HCG levels measured prior to the next chemotherapy cycle and should have 3 cycles after the HCG normalization. So if at all these patients are poor prognostic features they're having, these 3 cycles would further be extended to 4 cycles. Example, if today the HCG gets back to normal, if a normal patient, low risk patient, or the patient who is like otherwise having high risk factors is there, 3 cycles further we are going to do. But if it's a poor prognostic cancer, like that of liver metastasis, with or without the brain metastasis, then instead of 3 cycles, the extension would be 4 in the exam, right? I will go back once again for Rania, please. Rania, my dear, please have a look. Rania, just above the block, the RCPI here. Got it? Okay, perfect. Thank you very much. All right. Okay, so remember that for poor prognostic cancers, instead of the consolidation 3 cycles after normalization, it's going to be 4 cycles. Very welcome, my dear. So what is the difference? Just for your information, it's not in the guideline because these words are repeatedly being used. So you should be clear that consolidation cycles are different from the maintenance one. The consolidation are intensification therapy, like which are started off, right? And the maintenance is after the remission to maintain the avoiding the recurrence, okay? Now, after the remission is achieved in a cancer, the serum HCG should be measured fortnightly for 6 months, then monthly for a further 6 months, and every 2 months for 2 years. Now, I have to teach you today, and till the last session, you people have to make notes in this way so that the memory is better. You never remember the follow-ups like that. You make your algorithms. How? Fortnightly, after the remission is achieved, the serum HCG, beta HCG would be done for after 14 days for the 6 months, right? Then we are going to do monthly for the next 6 months, and then every 2 months for 2 years. These type of algorithms, one-liners you people would make, because in the last 15 days, we would revise these one-liners. It becomes very difficult if you keep the paragraphs for the follow-ups. So today I'm making you learn the exact way of learning and passing in one go. So this is going to be the right way where you are going to make your one-liners so that in last 15 days, we know that, okay, follow-up of everything is to be revised. We have our follow-ups in the form of algorithms. You will never forget for the single best answer. And these are different from that of the Green Top guideline. That's why I'm coming up with these recommendations. And even for the OSCE students, molar pregnancy is such an important case to come, both as a structured discussion in the examiner circuit and also for the long case viva as well. Okay. Now, there can be a possibility for the low-risk patients who have their FIGO scoring less than 6 or equal to 6, but still they're not having the chemotherapy selection as the best one, like the first line chemotherapy. Why? If they have, for example, the treatment related toxicity, or for that matter, the HCG in the 2 successive measurements 1 week apart is either rising or it's like a plateau, it's not getting lower down. So that means that this patient is not having the suitability for the first line chemotherapy. So this is the indication of the change in treatment of the first line chemotherapy. How does the question come in exam? The question comes with an age of a patient and she has been diagnosed with low risk gestational trophoblastic neoplasia. She has a score of 6 and she is started on the first line chemotherapy. So she is having the features of the side effects or the toxicity for that matter of methotrexate, or they give you an exam that in the successive measurements 1 week apart, the HCG levels are getting rising or they're plateau. So the answer would be, please change the treatment from the first line chemotherapy. Do people understand? The indications of the change of the treatment for the first line chemotherapy comes like this in the single best answer. So you should be knowing what are the indications of changing, despite she is a patient who has the first line, but you people should be knowing. So if you learn the guideline this way, there would not be a single point in the single best answer. You people would miss out. A wonderful update in May 2022, which is not in RCOG, is regarding the HCG levels and the methotrexate. I need your attention, everyone. There should not be any multitasking at the back. Please give me all your attention for next 15 minutes and then we are going to wind up, okay? For women with low risk gestational trophoblastic neoplasia who have not responded to methotrexate, who have the human chorionic gonadotrophin less than 1,000, the next line of treatment is actinomycin D. Now, Shazia, Rania, Muna, Amber, what do they give an exam? Preeti? They give an exam that the patient is having a score. When they say low risk gestational trophoblastic neoplasia, that means that they're talking about the FIGO scoring 6 or less, okay? So when they say that the score is 6, methotrexate has been given and HCG is raised, right? So if HCG on the successive test is raised, we did just in the previous recommendation, that's an indication of changing up the chemotherapy. Do you all remember? I just told you 3 points of the indication of changing the first line. Yeah, just in the previous slide. Perfect. Okay. Now you need to see the HCG to see what's going to be the replacement. If the HCG is less than 1000, then it is going to be actinomycin instead of methotrexate. Very well done, Rania. And if they say that she has not responded to methotrexate, the HCG is persistently raised and the value they give you more than 1000, then you people will choose the next line as a combination EMA-CO. Do you people understand? This is all update in our CPI. We don't have it in our COG at all. But these are the questions that will be coming up in exam. Why? Because it is only the Irish recommendations which give us these changes. We don't have these changes. So I'm going to highlight these changes. Otherwise, 70% of the curriculum would be the same, right? And this is just like a week back publication. So less than 1000 being raised, actinomycin, you people would select an exam. Thank you, Preeti, my dear. And if it's going to be more than 1000, it would be EMA-CO, right? Okay, that's perfect. Similarly, if they have a relapse and sequential single agent treatment is also not beneficial, then it has to be a combination therapy. I repeat that again. What do they mean by that? Okay, let's go back. That if it's a FIGO scoring, you have to answer me here, please. If the FIGO scoring is 6 or less, what's the first line? Come on quickly, please. What's the first line in exam? 6 and less, FIGO scoring. Perfect, methotrexate. All right. Methotrexate has been given and in the successive weekly HCG is raised. What is going to be the next step if it's raised? The change of the chemotherapy, right? Yeah. The beta HCG is less than 1000, but it's raised, persistently plateau or raised. So what's going to be the alternative to methotrexate? Very well done. Actinomycin D. Now I say that actinomycin D, she has not responded to actinomycin D. She still has a relapse. What would be the next step? Thank you very much. If she has not responded to the second single line agent, we would go to EMA-CO. The difference would be that we won't choose actinomycin D in exam if directly HCG is more than 1000. Then directly we'll go to EMA-CO. But if it's less than 1000, first step would be actinomycin D and second is going to be EMA-CO. Would I make myself clear? Do you find it easy now? Like in a systematic way we are learning together? Yes? Perfect. Okay. Now, any patient who is not low risk, who has from the very start the high-risk gestational trophoblastic neoplasia that is going to be more than 7 or more, then first-line treatment we know is EMA-CO. The next is going to be etoposide added, right? So we don't have a single agent, of course. We are going to have another second-line combination chemotherapy to be used. Why? Because in high-risk patients, 7 or more FIGO, we don't go with the single agent. We are going to have a replacement of a second line. So here we use the paclitaxel and etoposide instead of EMA-CO as a second line agent, please remember. Coming to the last few algorithms, which I love it because we don't have an RCOG. However, RCOG tells us the same. I was doing this from MRCPI and I thought I will be using this in my MRCOG session as well because it's beautifully given in terms of algorithm, which you people already know. So let's start because the single best answer comes from this. Patient with complete hydatidiform mole. So what is the treatment of choice? This is your first single best answer of exam. Thank you, Shaista, my girl. Thank you, Fatima. Evacuation, suction evacuation. Now my question is, I'll go stepwise, right? So you know that how the exam question comes. Second step is after evacuation, how frequently you people are going to do the beta HCG. This is the second single best answer they'll give you in a scenario. Very good, Rania. Weekly, weekly, weekly. Until the normalization for 3 weeks. Perfect. That's like my students. You all are awesome. If normalization is less than 8 weeks, what would be the follow-up? This is your 2018, 2019 single best answer. 6 months from the date of evacuation. If at all the normalization is after 8 weeks, then Preeti, Amber, Minahil, yes, it's going to be monitoring for 6 months post-normalization. Perfect. You people are great. And you are such a quick learner. You people are going exactly the way I want to train you guys for the MRCPI from day one. If at all, they give you a single best answer for the partial mole. So the drug of the method of choice for the treatment, we know is evacuation always, right? Monitoring serum beta HCG would be again, as we did in the complete molar pregnancy. And what's that? Weekly, 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 right? Until normalization. And the day it becomes normal, what are we going to do? In a partial mole, Fatima? Muna? Thank you. We are going to do 1 HCG confirmatory, an additional one 4 weeks later. Perfect. Hats off. Thank you very much. So we did it. This was May 2022 molar update. See, again, if you see this guideline, maybe out of 20 recommendations, 5 recommendations were newer one. So you just have to put up those 5 stick-ons on your molar pregnancy, and your MRCPI recommendations are done with your MRCOG only. Do people understand? This was just a glimpse of the preparation way which we are going to do. Definitely, yes, Shazia. You just tag Binte Hawa Myra, the moderators, please, or tag Safa there. You're just going to put that in there. Okay? It has not been told, Javeria. If the question comes, we are going to take it from the Green Club guideline. Now, Javeria's got a very beautiful question here, friends. Anything where our CPI is short of recommendation, we pick those recommendations up from the Green Top guideline, the talk articles, or the NICE guideline. Anything where we have the recommendation of the Irish guideline, we give it priority over the Green Top guideline recommendations. I mean, where it is a tie, where it is a clash, we prefer our CPI. And let me tell you, whenever there is a clash, 100% that question comes in exam. Because that is the differentiating point. Like, students have read those guidelines. All right. So whenever there is some comparison in the recommendations, we do the RCPI guidelines. And we prefer that recommendation for exam. Those differentiating points. I mean, those out of 20 recommendations, those 15 points are not very important, but the 5 differences are very, very important. Do you people understand the approach towards the MRCPI preparation? Do people understand that how we are going to make it easy? Now, no, Shazia, it's not like that. We would be reading all those Green Top guideline topics, the NICE guideline and the talk articles, which are not in the recommendations of the Irish source. Yeah, so we are going to do that. Sure, Talha, my dear. Talha, this one? Yeah, where I did the types of the chemotherapy, right?
Yes, doctor. Yes, yes.
Thank you very much. Thank you, Talha. Preeti, talks, I'm going to give you a 20 list. They have to be done only. And all these summaries of the recent ones, just in the recent exam, I'll share that exam with you guys once like we start the session module wise. In every, for example, gynecology, I'll do the recent questions with you, the recent exam questions. You people would understand that there are certain favorite talks and they just revolve around those talk articles. All right, Tala, it's nothing. It's just like taken from the Google. This, what is this EMA EP, etoposide and TET? That's it. Okay, I'm giving you that. What is the addition? If EMA co is not working, what is the second line? Got it? This is the chemotherapy. Javeria, we will do. Even 2021, we will also do, my dear. No, 2021, 2022, we will do because 2-3 new questions of the talk articles were there. Okay, so all the paid students, the complete single best answers would be available with you guys till 2022 from each talk article. The SP is made from the lines of the talk article by ourselves. Okay, that would be part of your portal. What you'll do is that you will do the talk and then you will see its question so that you analyze yourself. All the CPDs solved till the year 2022 would be part of your portal. because that book is separately being sold to the open students, but the core students have its access. So what you'll do is at least all the CPD questions you people would solve, and it's in the form of a book, and that's super easy to scan. All right. So you people would love it while just scanning in the form of a booklet online. So don't worry about that. All right. Okay. Yeah. So what would happen is that you people would just scan the CPD questions. You people would understand like the basic points and the single best answers as well. Would that be okay? Right? Okay, Preeti, same, my dear. You log into the site. Same as you people already do, where all the Green Top guidelines, the sessions are going to be. Shazia, we're going to do only those Green Top guidelines which are not touched in the recommendations of the Irish guidelines. And I will tell you module-wise. Module-wise, we are going to do. All right, got it, please? Okay, thank you very much. Now, my question to all of you is, did you people understand that how our approach is going to be towards each guideline, please? Okay, no problem, Sumaya. I was concerned, my dear. No problem. Go to the access on the website and just you'll have the recording. Okay, my dear? Okay, Shazia, did you get that? Kia, did you get that? Rubaba, you get that? Rania? My Irish students are not there. It was way early for them. So all my Irish students, please listen to the recording. I hope you people understand that. Yes? Okay, we have got a baby here, and that's Javeria's baby. All right, Javeria. Okay. Okay. Any question, please? It's clear, Rania? Thank you very much, Salma. All right. So now we are going to meet every week with one module. The topics of that module would daily for preparation by moderator would be discussed. So you people start practicing that in the live session. I will come up with the differentiating points. First, I will cover the Irish guidelines. Then I will cover those Green Top guidelines of gynecology and the TORG articles, which are not in the Irish recommendations, and we need to cover them. All right, no problem, Javeria. That's absolutely fine. Okay. Any questions, please? Talha, that's going to be there by the moderator. I will ask her to provide it to you guys. Okay. We'll tell Binta Hawa, don't worry. Okay. So you want to do it side by side from now? Amber, you're going to log into the website, RFA. So you're going to get that. Amber, write in the study group, please. Safa is going to tell you the link. Okay. Or write for the support, please. Website support teams. They're going to just give you the link. You just click on that link. The way, Amber, the way you did the payment, right? The way you had the sign up, that's where your all access would be. Yes, Mona, daily. Amna is going to do it. Myra is going to be there. Daily topic discussion would be there. If somebody misses out those topic discussion, please ensure that before sleeping, you go to the chat and you just basically revise it yourself. All right. Okay. Yeah. Daily, the topic is going to be discussed and you people have to revise that. It's very useful if you come on live with the discussion. If at all you're not able to do that, because retention is better with the live discussion, right? If you're not able to do that, then you can just before sleeping scan the discussion so that the points they're registered. Got it? Yeah? Shaista, got it, my dear? Muna? Okay, and all those friends who are doing the WhatsApp for joining in, please. This session, because that's an open session, 48 hours, you can put that coupon and you can join in with the same. All right, I'm talking to all those who wanted to join with this RFA booking gift coupon for 48 hours. And then we are going to come back to the original price. All right. Okay, thank you very much. Thank you. Anything you people would like to ask? Thank you, Riha, my dear. I'm so grateful for joining in. All my core students, half of them are not here. So you already are 100 plus. So you people just take care of your togetherness and try to have more effective participation, because more you're going to discuss with each other, better is going to be the memory. All right. And things are going to be better registered with discussion. The memory definitely is better. And once you'll be sitting in exam, all the points would be coming up to your mind so quickly that, oh, yes, we discussed this point. So more is the discussion, better it is, useful it is. Thank you very much, Rubaba. Happy to see you here, my dear. Thank you very much. Any other questions, please? Thank you, Preeti. Yes, see you soon in the study group, everyone. So every week we are going to meet now and we are going to have the module-wise discussion. From the gynecology, we are going to take a start, ending up with the early pregnancy. And all the updated 2022 recommendations I'm going to add on so that nothing is missed out. And I would study for you guys so that you people are easy and you people are just ready to appear in exam. All right? Thank you. Any other thing you people would like to ask, please? Anything you people would like me to repeat? Done? Perfect. So happy to start? Yes? Thank you very much, Sabah. So good to see you here, my dear. Shazia, I told in the beginning, we are going to do all the single best answer books daily. The schedule will be given to you. Thank you, Sumaya. I was missing you, my dear. That's my message. Ask Talha to message you. Thank you very much, Sumaya. All right. Thank you very much to all my older students who were here. Thank you,
Dr.
Fatma.
Sidra.
Thank
I
you
had a
very much.
question.
Yes, my dear Talha.
Dr. Sidra, will you cover all the Irish guidelines in the lecture classes and
Five
also
sessions
tell us about
all.
the clash
Yes,
between
yes.
the RCOG?
All, but I will not do number wise. I will do module wise. For example, the Gynae Irish, then the, all the Irish would be covered, but as per the modules.
As per module. Okay.
Yes,
and also
all
the
would be
clash,
covered.
where the differences are.
Definitely. I would mark the way I did it today. In each guideline, in front of that guideline, I would write that, okay, this recommendation you have to remember separately, please, because we don't have this recommendation in RCOG. Wherever it would be a difference, I'll mark it there and then in the live session.
And Dr. Sidra, please tell the team to share the recalls as well.
I will tell them. The reason is that it's like my fast track folder, but the PDF files they're going to share so that how about in just few days we start practicing. I'll tell them that we can start from 2015. Okay. Yeah.
Okay,
so like 30 minutes daily, you people can do a practice like 20, 25 questions a day won't harm, right? But it would give you the idea that how the questions are formulated and how much they're repeated. Okay.
Okay. Yeah.
We'll start it soon. I'll make a schedule for that. Okay.
Yeah. Okay.
Thank you very much. Sumaya, yes, my dearest. Yes, please.
Please, the slides that you are going to summarize for us and write the notes beside anything unclear. Will you send them on the Telegram group so we can memorize them?
No, it won't be in the Telegram group. It would be Rasha on the website and on
it's going to be uploaded anywhere.
Yeah, definitely. Yes. Just after like 4 hours, like this session would be uploaded. So it would be on your portal. You can open it 24/7 till your exam. That would be with you.
Okay. Thank you very much.
Okay. So, and you can revise it as many times, my dear, in the form of a recorded session, as many times as you want. Okay. Okay. Thank you very much. All right. Yes, Rubaba, my dear, people are doing like that. They are doing back-to-back exams because I told you that 75% of the preparation is same. After MRCOG, Rubaba, MRCPI is very easy. What's the reason? Reason is that we don't have extended match questions and you just have to do, for example, this molar pregnancy, you listen to it once, you see, okay, 5 recommendations are different, you put them together. For example, Talha, you make a separate notebook, my dear, and you make a separate notebook where you put in the Irish recommendations of molar. So those differences, if you just only learn, rest is all the same. So you just scan your own notes and the differences you put together. That's it. This is the ideal way of doing MRCPI. Okay, you people won't find difficulty. If you'll start writing the notes from the beginning and scratch and from zero, that would add on to burden. And I know you guys, because I know your background in terms of MRCOG. I know I've taught you all the things myself, right? So I know that you people don't need it from the basics. You people just need to add on the information, which is new. And I'm going to learn and teach you those, okay? So you know the comparison I'm going to make for you guys. You just need to register them. That's it. All right. Thank you very much, RFA Tutors team. Hats off. Thank you very much for wonderful support out there. Thank you. Okay, Rubaba. Yes, my dear, do that, please, side by side. People are taking together my July students after 5th July. They all would be joining in here, the ones who want to take MRCPI. So back-to-back students, they do it. Why? Because they have the baseline. They don't have to put in like additional efforts. Okay? Right. Any other question, please? Okay, that's perfect, Salma. That also means that you've got a wonderful knowledge of obstetrics and gynecology. So we just need to know the differences between ACOG and the MRCPI. Okay, that's perfect, Salma, my dear. You will do it. Yes. Thank you very much. Thank you. That's perfect, my dear. Thank you. All right. Any other question, please? Am I clear? Did I come to that level of understanding, which I actually wanted to give you my peace of mind today? Did you people exactly understood that? What do I expect from you guys in the course? What do I expect from you guys in the sessions? After the sessions, you all have to be pretty clear. And that's going to be like my success if you people are trying to study the way I did for myself, the way I was successful. I want you all to be successful in the same way, and you people would see. Your aim should be September MRCPI and November MRCPI OSCE. So you just get over with this degree back to back. All right, thank you very much. So we did it, friends. So we are going to meet every week for module-wise discussion. So best of luck from the entire team of RFA tutors. Thank you for a very healthy discussion today. Lots of love, prayers, and wish you all the happiness and success. See you all in the study group. Bye-bye from the entire team. Thank you very much for being awesome listeners today. And thank you for a wonderful participation. Bye-bye from my side. Take very good care of yourself. Thank you, Preeti. Thank you, Shaheen, my dear. Thank you, Rania, Javeria, Rihanna, Rania. And love you all. Take care, very good care of yourself. See you guys in 1 week's time and stay in touch in the study group. Bye-bye.